Welcome to today's Explainer. We're diving headfirst into a true medical emergency, meningitis. We're going to explore exactly why every single second counts when the body's ultimate fortress, your brain and spinal cord, comes under a direct microbial attack. So let's just jump right in.
Here's our roadmap for this explainer. 1. Intro and global epidemiology. 2. Etiology and risk factors. 3. Pathophysiology of the brain. 4. Clinical signs and mimics. 5. Diagnosis and emergency management. And 6. Complications, prognosis, and prevention.
Starting off with Section 1, Intro and Global Epidemiology. Let's look at the threat and the scope. So the really crucial point here is that meningitis is an attack on the very fortress protecting our nervous system. Your meninges are basically made up of 3 anatomical layers, the dura mater, the arachnoid mater, and the pia mater. When an infection or severe inflammation breaches these layers, especially the subarachnoid space, which is this vital, delicate gap where your cerebrospinal fluid flows and your major blood vessels sit, well, you've got meningitis. The pathogens invade this space and just trigger a massive, overwhelming inflammatory response. And because this inflammation happens in such a highly critical area, the clinical presentation is usually sudden and severe. Seriously, if you take absolutely nothing else away from this explainer, remember this classic triad: fever, neck stiffness, and altered mental status. Now, granted, not everyone is going to show all 3 of these at the exact same time, but recognizing them rapidly, that's absolutely crucial because this condition can spiral into brain injury, septic shock, or even death in a matter of hours.
Now, what's genuinely fascinating and a bit scary is how the microscopic villains change entirely depending on the patient's age. For neonates, the primary culprits are Group B Streptococcus and E. coli. But as we move into children and young adults, Neisseria meningitis becomes a massive threat. And looking globally, the absolute highest burden of this bacterial mortality happens in the African meningitis belt. This stretches right across sub-Saharan Africa, where these intense seasonal epidemics flare up during the dry season.
Moving on to Section 2, Etiology and Risk Factors, the invaders and the weak points. So, while bacteria are incredibly deadly and, they usually get the most attention, they definitely aren't the only invaders. Viruses, particularly enteroviruses, which are actually the most common cause of aseptic or non-bacterial meningitis, as well as things like the herpes simplex and varicella zoster viruses, can also trigger the disease. Oh, and we also see fungal causes, like Cryptococcus neoformans. These are especially common and dangerous in immunocompromised patients, like folks living with HIV or AIDS. So what actually leaves the gates open to these invaders? Basically, any condition that breaches the blood-brain barrier creates a perfect storm. Extremes of age, immunosuppression, and crowded living conditions are your major systemic risks. But anatomically speaking, if someone has a skull fracture, a recent neurosurgical procedure, or get this, even just a chronic ear or sinus infection, pathogens suddenly have a much easier direct access route straight to the meninges.
All right, Section 3, Pathophysiology of the brain, the fortress breached.
You might be wondering, how do these bugs actually get in? Well, the most common way is literally by hitching a ride in your own bloodstream. We call this hematogenous spread. The other routes are direct extension, which means it physically spreads from an adjacent sinus or ear infection, or direct inoculation, like from trauma or surgery. And once these pathogens reach that subarachnoid space, they have a terrifying advantage. Your spinal fluid has very, very limited immune defenses, so they multiply rapidly, like wildfire.
This wild bacterial multiplication triggers an intense inflammatory cascade. Cytokines and neutrophils completely flood the area. Your blood-brain barrier becomes highly permeable, leading to cerebral edema, which is basically the brain swelling up. But here's the catch. The human skull is a rigid, closed box. So this swelling causes a massive spike in intracranial pressure, which literally physically crushes blood vessels and chokes off cerebral perfusion. It even squeezes the cranial nerves traveling through the space, which is exactly why patients can suddenly develop double vision, facial weakness, or hearing loss out of nowhere.
Which brings us to Section 4, Clinical Signs and Mimics, Experiencing the Attack.
The clinical presentation can actually look drastically different depending on how old you are. Adults usually experience a severe headache, a really profound sensitivity to light, that's photophobia, and extreme neck rigidity. Doctors will actually look for specific positive meningeal signs, like the Kernig and Brudzinski signs. And if the infection is caused by Neisseria meningitis, you might even see a purpuric rash, which looks like tiny red or purple spots on the skin. But here's the thing, infants won't tell you their neck is stiff. Those typical signs are totally absent. Instead, you're looking for a bulging soft spot on their head, the fontanelle, along with extreme irritability and just really poor feeding.
The real challenge for medical professionals, though, is that a bunch of other really severe conditions try to fool us by mimicking meningitis. We have to quickly establish a differential diagnosis to distinguish it from things like encephalitis, a subarachnoid hemorrhage, a brain abscess, or if we're in an endemic area, even malaria. We've got to rule these mimics out super fast, which brings us to arguably the most critical part of this explainer.
Section 5. Diagnosis and Emergency Management. The counterattack.
So, the absolute gold standard for diagnosis here is cerebrospinal fluid analysis, which we get via a lumbar puncture. To figure out exactly what we're up against, we use this diagnostic decryptor table. By testing the fluid, we instantly know the threat. If neutrophils are high and glucose is low, it's bacterial. The bacteria are quite literally eating the glucose for energy. If lymphocytes are high with normal glucose, it's likely viral. This one distinction dictates the entire treatment plan. Just a quick side note though, neuroimaging, like a CT scan, might actually be needed before the puncture if there are signs of dangerously high intracranial pressure. Because meningitis is a race against the clock, before we even try to attack the bug with drugs, we have to stabilize the patient. This is a true medical emergency, folks. Management always begins with the ABCs, securing the airway, getting oxygen therapy going, establishing intravenous access, and starting fluid resuscitation just to keep their blood pressure up and keep the brain properly perfused.
Then, we launch a massive empiric antibiotic strike right away. You absolutely do not wait for the final lab cultures to come back. Immediately after drawing blood, patients are hit with heavy-hitting antibiotics, like ceftriaxone or vancomycin, and if listeria is a risk factor, ampicillin. Crucially, we also use adjunct therapy like the steroid dexamethasone. Why? To blunt that totally devastating inflammatory cascade we talked about earlier. We have to stop the brain from swelling further as the bacteria rapidly die off.
Finally, Section 6. Complications, Prognosis and Prevention. The Aftermath.
I really want you to just look at the staggering number, 10 to 30%. That is the mortality rate for bacterial meningitis, even with state-of-the-art modern medical treatment. The prognosis depends really heavily on the causative organism, the age of the patient, and how incredibly fast treatment was started. Now, viral meningitis generally has a much better prognosis, but bacterial, it remains a highly lethal threat.
And for those who do survive the initial attack, well, they're often left with permanent battle scars from the intense inflammation that damaged their brain structures and cranial nerves. These complications include hydrocephalus, which is a buildup of fluid in the brain, seizure disorders, cerebral infarctions or strokes, and very commonly severe hearing loss. Long-term neurological and cognitive deficits are just tragic realities for a lot of survivors of this disease.
But hey, here's the good news, and honestly the most actionable takeaway from this whole explainer. We can absolutely stop this invasion before it ever starts. Prevention strategies are incredibly effective. Routine vaccines like the meningococcal, pneumococcal, and Haemophilus influenzae type B vaccines have drastically reduced infection rates all over the globe. Furthermore, if you are a close contact of someone who comes down with Neisseria meningitis, taking preventative antibiotics, chemoprophylaxis like rifampicin, can literally stop the bacteria from taking hold in your system. So we've seen firsthand how quickly this disease can breach the body's defenses, swell the brain, and cause permanent devastation.